and welcome everyone. It's my pleasure and honor to introduce our friend, Bernie Gersh from Mayo Clinic in the United States, who will be presenting a very important talk entitled Long-Term Sequelae of COVID-19 Research Directions and the Critical Need for Prospective Longitudinal Follow-up Data. This talk has been waited for, Bernie, by many of our colleagues, and they're waiting for you to tell us about what's new and what we know, what we don't know about this terrible pandemic. I have the pleasure of having with me as co-moderator of this presentation Mo Jailan from Nairobi, Kenya, and David Kettles from South Africa. Welcome, everyone. Bernie, welcome again.
Thank you very much, Habib, and I'm very pleased to be part of the Pafcic meeting again. I really enjoyed visiting Tunis last year, and I hope that next time we meet, we'll be meeting face-to-face again in a happier 2021. So COVID dominates the headlines, and what I want to really just talk about is something that I think is very interesting with a lot of unknowns. That is the long-term sequelae of COVID-19 and research directions and the critical need for prospective longitudinal follow-up. Because the pandemic acutely will go away, but we may be left with long-term issues and complications, and that's what I want to discuss. Now, although COVID is really the severe acute respiratory distress syndrome, what I think we've all realized very early on that this is a systemic disease that attacks virtually every system in the body. And what I want to focus on is post-acute COVID, the clinical picture, which includes patients who come out of the ICU, but also patients with mild to moderate disease. Now, of the manifestations, many of them are non-specific. Fatigue, chest pain, joint pain, dyspnea, tachycardia, and that may be part of what is called the long haul syndrome, with a real disturbance on emotional health and well-being. And although I'm going to focus on the cardiovascular complications, I do want to just mention a couple of general comments about post-acute COVID in this talk. Now, cardiovascular, some of these symptoms, these non-specific symptoms, may actually be due to cardiac disease, but it could also be that it's a bidirectional phenomenon. The lungs clearly are affected chronically and then neurologically. It's often useful to ask these questions. Do we know the natural history of post-acute symptoms and complications? Do we know the etiological mechanisms? And the answer is we do not. This is a really good editorial by Peter Libby and Tom Lucia in the European Heart Journal. COVID-19 is in the end an endothelial disease. And they talk about the protein manifestations ranging from head to toe. And one of the few systems in the body that really does go from head to toe is the endothelium. And they postulate, and I think are correct, that what happens in severe, or not even necessarily that severe COVID-19, is that the homeostatic and defensive functions of the endothelium overreach and turn against the host. So the endothelium, which is protective, but once it becomes really inflamed, it can be maladaptive and turn against the host. It's always interesting to go back and look at history. And this is an interesting study or article on the history of influenza. And Kilbourne, Kilbourne is a well-known infectious disease expert in the US who died recently in his 90s. And then he quotes Churchill here and says, if influenza is a riddle wrapped in a mystery, inside an enigma, then the viral genes are the riddle, the variable surface antigens for which they code are the mystery, and the course and cause of epidemics, the ultimate enigma. It's interesting. This was a quote by Winston Churchill in 1939 when he was talking about trying to understand the Soviet Union. Well, if in this, again, this historical article, they refer to the Spanish flu in 1918, 1919. And von Economo is an Austrian physician who described the entity of post-influenza encephalitis, called it encephalitis lethargica. And this led to an epidemic of Parkinson's disease in 80% of survivors. Now, in Lancet Neurology, about a month or two ago, was a clear description of a young Israeli man in his 40s who had COVID and within 2 months had a syndrome indistinguishable from severe full-blown Parkinson's. Now, in regard to the long haulers, this is a good review that talks about the puzzling persistence of symptoms. 10% in one UK study, majority not hospitalized, affects older and younger patients, and I might add, I think disproportionately affects women. And many of these patients were previously active, healthy, almost a disproportionate number of runners in this syndrome. And Anthony Fauci then made this quote, "Anecdotally, there is no question that there are a considerable number of individuals who have a post-viral syndrome that really, in many respects, can incapacitate them for weeks and months following so-called recovery and clearing of the virus." And why I think this is so important, the so-called long haulers, is many of these people want to go to work and cannot. So it's going to could have a major effect, not just on morbidity, but on productivity, and we just don't understand it. This syndrome also has a relationship to other conditions, post-traumatic stress disorder, chronic fatigue syndrome, the post-ICU syndrome, which is well documented, postural orthostatic tachycardia syndrome, and inappropriate sinus tachycardia. I can tell you that as an electrophysiologist, patients with these conditions are a nightmare. They are very difficult to treat. And all of these are seen with other viral infections. POTS is well documented to have occurred following a viral infection. This comment from a neurologist in the Rubin editorial, one thing that is clear is that these mystery diagnoses are real and they're not just in patients' heads. And I agree with that. Now, if you look at the manifestations of cardiac injury and COVID, they are multiple and multifactorial, and it's a bidirectional interaction. Cardiac injury, the pathophysiology, severe sepsis, hypoxemia, the cytokine storm hypothesis, I think, has not really held up. What is now seems to be more plausible is the bradykinin hypothesis, coagulopathy, macro and microvascular, endothelial and microvascular inflammation and dysfunction. That's the pathophysiology. The manifestations, increased sympathetic nervous system activity, sets the stage for inflammation and plaque rupture and type 1 MI. The factors, hypoxemia, myocardial oxygen demands that are increased, predisposed to type 2 MI. Takotsubo is described, not as frequent as I would have expected, but it's described. And then thrombosis, arterial and venous, which I think plays a major role in the pathophysiology of this condition. It seems to be more platelet dependent. There is some evidence that tissue factor is released by the inflamed endothelium, and that is a very, very potent clotting mechanism. This is virally mediated endothelial inflammation, tissue factor, and hypercoagulability. The clinical manifestations are very wide, from troponitis, chest pain, MI, shock, RV dysfunction due to high pulmonary vascular resistance, pulmonary emboli, arrhythmias, pericardial involvement, PE, stroke, and microvascular dysfunction. Modifying factors really are important. Delayed presentation to the ED, delayed diagnosis, pre-existing comorbidities, including age, obesity, and cardiovascular disease. Fever, drugs, including antivirals, which may interact with other antiarrhythmic drugs, electrolyte abnormalities, and then logistical constraints during an pandemic. To illustrate the impact of CV disease and mortality, this is an acute study from Wuhan in China. 23% died. If they had no preceding cardiovascular disease, normal troponin T, 7.7% mortality at 50 days. With CV disease and normal troponins, 13.3%. Without CV disease and troponin elevation alone, 38%. And then the combination of pre-existing cardiovascular disease and elevated troponins, 70% mortality. This study from 7 hospitals in New York City and Milan of 305 patients who had an echo during hospitalization, a whole range of abnormalities, global dysfunction, right ventricular dysfunction, wall motion abnormalities, pericardial effusion, diastolic dysfunction. But what is interesting and important again, no myocardial injury, 3% mortality. This is at 25 days, I think. Myocardial injury without echo abnormalities, 17%, and the combination of the two, 35%. Now, what we have seen in a number of studies recently is that abnormal imaging findings in recovered patients are frequent. What I'd like to do is move away from the acute illness to the chronic. What is the significance of these? How do they correlate with symptoms and severity of the initial illness? And what is the natural history? Do they resolve? Do they persist? Are we going to see late heart failure? Are we going to see late arrhythmias? When can people return to full activity? And I'll come back to this in terms of athletes. So this was the study that was published earlier this year that set off alarm bells everywhere. From Frankfurt in Germany, Andreas Zayer's group, 100 patients, only a third were hospitalized, mild or no symptoms, 49 and 18%, mean age 49 years, comorbidities were frequent, and the CMR was on a median 71 days after diagnosis. So they'd recovered. But at the time of CMR, 76% had elevated high sensitivity troponin T. Well, abnormal CMR findings were found in 78%. Non-specific findings, but abnormal. Increased native T1, increased native T2, and then late gadolinium enhancement in 32% of patients. This was followed almost a month later by this letter, which again set off alarm bells, understandably. 26 competitive athletes from Ohio State University who were COVID positive were not hospitalized and underwent comprehensive CMR. And 46% had findings that were clearly abnormal, edema on T2 mapping. And this is more concerning, late gadolinium enhancement without T2 elevation, and that does suggest prior myocardial injury. And the T2 mapping in itself is non-specific, but this again raised all kinds of alarm signals. After all, they were recovered, they were never hospitalized, and almost a half had these abnormal findings. This study from Brazil is similar, but the results are different. 48 athletes who had CMR imaging, mild to moderate symptoms, not severe, 27 days after diagnosis. And in this study, the inflammatory biomarkers were not elevated. In the previous 2 studies I showed you, biomarkers were elevated, troponins. Well, 56% had an abnormal CMR, but here the emphasis was on the pericardium, with effusion, without effusion, but some other, non-specific findings. Late gadolinium shouldn't be reduced. it should be increased without increased native T1 mapping in 14.6%. And they then say no images of myocardial inflammation, and I'm not quite sure what is meant by that. But the emphasis here was on the pericardium, but there are some other myocardial abnormalities. Now, you may think that I've lost my mind here when you look at the title, the duct test, myocarditis and communists in Guatemala. And if you are surprised by the title and think I've lost the plot, I can quite understand that. But this is from a comment by the United States ambassador to Guatemala in the 1950s, at a time when there was this widespread hysteria that the communists would take over would take over Latin America. And so he was asked how he could tell a communist. He said, suppose you see a bird walking in the farmyard. It has no label that says duck, but it looks like a duck. It then goes to the pond and it swims like a duck. And then he opens his beak and he quacks like a duck. Well, by this time, you've probably reached a conclusion that the bird is a duck, whether he's wearing a label or not. And then he goes on to say, and that's how I can tell a communist. Well, in the context of COVID, I'm going to change it. Perhaps what looks like typical myocarditis is in fact something else. Question mark. So CMR abnormalities are frequent in patients recovering from COVID-19. And I've showed you 3 or 4 studies that point that out. This is myocardial injury. Is it myocarditis? I don't think we know. First of all, late gadolinium enhancement in a non-ischemic pattern can be due to myocarditis or myocardial permanent injury. It can also be due to microvascular obstruction. Abnormal T1 and T2 mapping and weighted mapping are non-specific findings. Edema, fibrosis, recent injury, but that may not be the same as our traditional concepts of lymphocytic myocarditis. And how do we interpret these in terms of elevation or no elevation of inflammatory biomarkers? And this is a lot that has to be sorted out. Because I think we all felt a couple of months ago that these changes were due to myocarditis, lymphocytic myocarditis, but not so. And this recent publication from a pathologist at Hopkins, 227 autopsies, 21 publications from 9 countries. And he says initial review of the data indicate that myocarditis was present in 7%. But if you really look at it in more detail, it's much lower than that, less than 2%. In conclusion, across 277 cases, COVID-related histopathological findings were common, 48%, but myocarditis was rare. And these are the 21 studies, and he points out that the perception of a high incidence of myocarditis really comes from one study where they had an incidence of 12%, and that created the figure of 7.2% if you aggregated the data. So suggestions here that myocarditis pretty uncommon. This is a study from Louisiana, patients who went to autopsy, and they speculate on the mechanisms for cardiac injury that should be investigated to provide a better understanding of the cardiac manifestations of COVID-19. Now, this was largely an African-American population with many comorbidities, mild troponin elevation, and they died of respiratory failure. At autopsy, the commonest findings, severe RV dilatation, no myocyte lymphocytic infiltrates, and when they looked for the presence of COVID-2 virus particles, they were in small vessels, endothelial cells, pneumocytes, renal tubular endothelium, and not in the cardiac myocytes. And I want to point out, if you look at the histology of an alveolus, what you will see is that the endothelium of the vessels adjacent to the alveolus are extremely close to the actual pneumocyte itself and the alveolus. Another study presented at TCT, 40 autopsy patients, COVID-19 deaths, cardiac injury in 14 of these, evidence of myocarditis, 0, viral particles in the heart. In this study, 9 patients. In the previous study, none. 3 of these patients had myocardial infarction and focal necrosis in 1 patient. This, I think, is the key. The presence of coronary thrombi in these patients with cardiac injury, epicardial in 2 patients, microthrombi in 9 patients. I still think that coagulopathy or thrombosis, both micro and macrovascular, is going to turn out to be a major pathophysiological mechanism in this condition. And right now, Val Fuster in New York is running a large trial of various forms of anticoagulation in hospitalized patients. So is myocardial injury and COVID-19 infection due to myocarditis? This is a question mark, and this is from a colleague at the Mayo Clinic, and this paper is under review in Nature, but he allowed me to show it. And what he has been able to show on electron microscopy is that SARS-CoV-2 causes direct cardiac damage through spike-mediated cardiomyocyte fusion. And what is meant by that is this is not myocarditis. He feels that the spike glycoprotein, which is the hallmark of this virus, can exploit the electromechanically coupled myocytes, the gap junctions, to drive heart damage directly, uncoupling clinically common myocardial injury from lymphocytic myocarditis, often suspected, but rarely confirmed. And these images are absolutely spectacular. And you can see the direct effect on the myocyte and how they've changed in such a way that the synchronous connectivity of the heart is lost and could predispose to arrhythmias. So what do we know? Late sequelae. Cardiac injury during the acute phase of COVID-19 is common and an adverse prognostic factor. The etiology is multifactorial. In COVID survivors, cardiac abnormalities on imaging are frequent, irrespective of the severity of the acute illness. All of those studies I showed, these were relatively mildly symptomatic patients. What don't we know? We don't know what the natural history and clinical significance is of these abnormal findings in acute survivors. What do we do with competitive athletes? And are the prior guidelines on myocarditis that have been published, do they apply to this COVID population? We don't have a clue. Remember, many of these people, this is how they're going to earn their living. Do we have correlations between these imaging findings and pathology and histology? We do not. We have these studies published that have set off alarm signals, but we really know so little. And then the mechanisms and etiology of the different manifestations of virus in the heart have to be established. But what are the research directions? I've repeatedly said that myocardial injury is multifactorial. And Mo Jalen and I were discussing this just before the session started. These are going to be difficult to do. Mechanistic studies correlating morphology, histopathology, and imaging findings. Clinical studies, I think there are a number of questions. We need prospective clinical studies that look at functional status and symptoms, survival, and really what is the late morbidity? Are we going to see late heart failure and arrhythmias? Will we see an epidemic of dilated cardiomyopathy? Much like in the pandemic of 1918, encephalitis lethargica led to Parkinson's disease. What do we measure? I think a number of parameters. CMR, stress testing, biomarkers. I think event monitors are going to play an important role in seeing whether we have late arrhythmias. Echo PET. And the design must be prospective. Sample size has to be adequate. Prospective longitudinal follow-up. And then I think this is really important. We have to really specifically phenotype the patients. They're not all the same. And I really do think that we need studies on competitive athletes as one particular phenotype. But to simply think that all people with some abnormalities after COVID or some cardiovascular abnormalities are the same is ridiculous. We need to really specifically phenotype and understand which patients we study. Now, this is a really interesting kind of paradox. We have a pandemic that we believe and hope will disappear in 2021. And, but if it does, and it disappears in terms of being an acute injury or an acute disease, we're still going to be left with the sequelae of this. And if we're going to study the sequelae, we have to start doing it now, while there still is the pandemic, because we're not going to find the patients that easily later on. And so what do I think? I think, first of all, this is a very excellent editorial in the European Heart Journal. The significance of COVID-19 associated myocardial injury, how over-interpretation of scientific findings can fuel media sensationalism and spread information. When I first saw that MRI study with 74% of people with abnormal findings, I immediately thought, oh my God, all of them are going to come back with cardiomyopathies. Well, it's not that simple. And one of my favorite quotes from Mark Twain, what gets us into trouble is not what we don't know. It's what we know for sure, but it just ain't so. And that's the situation we're really in. So my concluding slide, profound thoughts about the epidemiology and natural history, I think I should say, of COVID-19, is what we do know for sure is that there is a great deal more that we do not yet know. And we're going to have to start thinking in terms of the pandemic may come to an end, but we don't know what the sequelae will be. And the time to start studying them is now. And there are registries in the world of COVID and cardiovascular disease and acute cardiovascular disease. And hopefully the people in these registries and in organizations like Pafcic can be marshaled to answer some of these really profound questions that we have to answer in the future. Thank you very much for inviting me to give this talk. And I think we've got a few minutes for questions.
David. Thank you very much, Veroni. Thanks. That's a brilliant lecture, as usual. As you said, you gave us a good amount of information, but there is a substantial amount of information that we don't know, and unfortunately, we have to wait until we know what's going to happen.
I think it's always useful to be able to summarize what we don't know as well as what we do know. Because it's actually,
Can I kick off with a question, Bernie?
Of course.
You know, you spoke a lot about the CMR findings. You know, you mentioned at the end again the German study showing all these abnormal MR findings. Are you aware of? Do we have any similar interrogation of other multi-system viral syndromes? For example, H1N1 influenza. Are you aware of any other post-viral CMR studies which we could compare with the data that's coming out on COVID? Or is there a big dearth of information there?
You know, it's a good question, and I don't have the answer for that. I've seen odd mention in the literature that H1N1 and other viral syndromes cause lingering effects. That we know. And I pointed out that some of the non-specific symptoms in COVID really do mimic other viral diseases and people with post-ICU syndrome, POTS, inappropriate sinus tachycardia. That we know. I don't know, but I'm certainly going to try and look this up. I do not know of MRI studies or even similar other imaging studies of the cardiovascular system with these viral diseases. And I'm really glad you brought that up. I'm going to look that up. The fact that I'm not aware of them doesn't mean they haven't been done.
Sure.
I think my guess is that probably not to the same extent, because I don't think these other conditions were quite characterized as much by the cardiac injury as has COVID.
Yeah.
But it's a really good question, David.
Sure. I mean, I've been fascinated in my own limited follow-up. Because we've had such a COVID outbreak in our hospital, I'm seeing sort of post-COVID patients on a daily basis in the clinic. And I was interested right at the beginning of your talk in the slide that there's just so much, there's so many symptoms, and yet on basic echo interrogations, we're not finding a lot of pathology. I expected at the initial part of our experience that all these patients were going to come and I was going to find that they had blown RVs and evidence of pulmonary hypertension and some regional wall motion abnormalities and all those abnormalities that you find. But by the time they're coming to me for a post-COVID examination, they're complaining of atypical chest pains, palpitations, discomfort with breathing, and all sorts of things. And we're doing a sort of general cardiovascular examination and really finding nothing and saying, hang on, it's going to go away.
Well, it probably is. It's going to take an awful long time. I mean, they're going to be very difficult to treat. And I actually think, and I've heard some discussions that some centers are setting up post-COVID clinics that are multidisciplinary. You know, they can't concentrate. I saw one patient. I was consulted about one patient who's a 34-year-old physician, and she had mild COVID, recovered, and now has classical microvascular angina, endothelial dysfunction. But I think if you can, I know you've got your hands full with the epidemic or pandemic right now, but it would be valuable if that kind of experience can be published. I mean, you know, the African Heart Journal would be one really good vehicle, just simply to say, well, we have 100 patients who had abnormal echoes, and when we saw them 3 months later, 90% of them had resolved. That would be really important information.
Bernie, may I ask you a question? I don't know if you have seen anything across the risk of reinfection. These patients, when they're over with their acute phase, do you think they still have the risk of reinfection? And if there is any protection for how long?
Habib, you're talking to a simple cardiologist, not an infectious disease expert. And I do know that there have been cases reported of clear reinfection, but I think you can count the number of cases on one hand, apparently. Now, if you think of the millions infected, there was one or two from South Korea. I mean, there have only been very few reported cases of symptomatic reinfection. And in one or two of them, the second infection, they were sicker than with the first. But there are very few. And but it has been reported, but it seems to be pretty few.
Yeah, I think, Bernie, I saw your unmet needs slide there, and I must say, it occurs to me that I need to have a chat with our interventionists, because imagine if we could get a study together and do a serial echo on the patients who have abnormal echoes and raised troponins in ICU, and then put in a loop recorder or something. You know, we could generate
I think it would be amount of information. I think it'd be tremendous. I mean, look, it's got to be really tough to do research when you're just overwhelmed with the logistics and mechanics of treating the patients. but this is really going to be an unmet need. And when the pandemic goes, as it will, as every pandemic ever has in the world, from the Black Death onwards, as it disappears, it may be more and more difficult to find the patients and do the studies.
Yeah.
So I think it's time to think about them. And I just think what you have just described as a clinician is enormously important. You've just said you've seen all these patients with abnormal echoes, and then they come back with non-specific symptoms, and they seem to be, from a cardiovascular standpoint, well. We really need to document that. And then I do know that I think the Sports Institute in South Africa is looking at this in athletes. I know of a study that may be coming out of Pretoria, an MRI study. Arun, I apologize, but I'm going to have to sign off.
Thank you so much. Thank you so much, Bernie. It's always a pleasure and an honor seeing you with us. Your lecture was absolutely outstanding, as usual. So thank you so much for having taken the time to be with us. And hopefully next year, this COVID-19 will disappear, and then we'll meet face to face in Marrakesh, in Morocco, as promised.
It would be wonderful to. I think Zoom has been a life-saving phenomenon, but boy, it'll be nice to be able to have the camaraderie and the fun of meeting together.
Absolutely. Thank you very much.
2021.
Thanks, Bernie. Enjoy the rest of your evening.
Thank you so much. Thanks, Dave. Thanks
you very much, Abib. Thanks for the invitation.
And we'll see you tomorrow, I hope.
And congratulations on your meeting. Cheers, Ab.
Thank you very much. So now we're going back to Raj Makar in LA to see what has done with his case, and then we'll end the day with a NOAC's presentation in clinical practice that starts hopefully in 10 minutes from now. Thank you, Dave. Bye-bye.
Thank you very much. Cheers, Abib.
Thank you.